Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. Hope everyone had a good weekend, that you are surviving the heat. I just got back from a trip to visit my daughter in Arizona, and we were at 109, and it was muggy there. I thought it was supposed to be a dry heat, like here in California. No such luck. But we are at the last Tuesday of the month, which means this is Talk 10 Tuesday. And so I'm going to give you today, I'm going to talk about the top 10 medical mistakes that practices can make that can really cost you not only money, but time in fixing the mistake and having to possibly send a correction, and then the spiral effect of having to possibly refund not only the insurer, but the patient if you were paid incorrectly, or let's say you weren't paid enough, and then there may be an additional out-of-pocket for the patient. So a lot of this comes from a recent blog I was reading on the American Medical Association, the AMA website, but also in my auditing work, and then also most recently in some of the coding questions I've been responding to from my membership clients. I've got a lot of material today. So let's go ahead and kind of get started and figure out just really where do we want to stay away from when it comes some of these mistakes that could really cost you. For right now, government and private insurer audits, they've really revealed, unfortunately, some cases of fraudulent or abusive medical billing practices. Now, you deserve to be paid for what you provide, the medical care you provide, but it is essential that you avoid improper billing practices and certain mistakes as we get back out of the pandemic, as we're trying to move forward and hopefully build our practices back up and not rely on pandemic money so much as the provider relief funding and PPP loans. We need to start really building our practices so that not only are we not tagged into the broad category that HHS has and OIG has for fraud and abuse, but that we can not only hold on to our money, but hopefully improve our reimbursement by avoiding certain mistakes. So when it comes to medical coding errors, again, they fall into broad categories: fraud, and I'm air quoting, and then abuse, and I'm air quoting again. So fraud involves intentional misrepresentation. At least that's what it means to me. Sometimes CMS and OIG, even if they don't find actual intent, they still may call it fraud if the physician knew prior to that this could be a problem. Now, the latter, the abuse, means the falsification was an innocent mistake, but nonetheless representative of abuse of the system. And this is also in the AMA Principles of CPT Coding, 9th edition. So an example of abuse could involve, let's say, coding for a more complex service that then was actually performed due to a misunderstanding of the coding system. Now, I see that a lot. Unfortunately, I see it a lot now in telehealth, but this has happened quite a bit lately, and we just want to make sure that we're not overstepping, going outside the lane when it comes to coding appropriately. And we just want to really avoid some of those medical mistakes. But I like to also call them really common mix-ups, let's say it that way, because I find it rare, and I do a lot of Medicare auditing, that it is always intent, almost never. It's just more mistakes that they should have known better, but we have to get on board to make sure we're doing things correctly. So one of the common mistakes is unbundling codes. So when there is a single code available that captures payment for the component parts of a procedure, that's what should be used. So what unbundling refers to is using multiple CPT codes for the individual parts of the procedure, either due to misunderstanding or in an effort to increase payment, or the fact that you haven't updated your CPT book to the current year. One thing that comes in mind, just a perfect example, is a medial meniscectomy of, let's say, the right knee. So you're repairing or taking out a torn meniscus, and then a chondroplasty, which is shaving of that area around the patella or in that medial or lateral space. Well, years ago, I think it's now 5-6 years ago, the code 29881 was now inclusive, or has now included, the with or without chondroplasty. It doesn't even matter if it's in a same or different compartment. But because back in the day, the doctors were getting paid for both the 29881 and the 29877, I've seen two things happen. I've seen the doctors still try to slide it by and say bill it anyway with a 59 modifier, which is incorrect, and that's an error. Or they basically will, and I hate to say this, but I have seen some manipulation of the documentation to try to get it paid, and we have to not do that. Remember, there are 4 codes that it's inclusive, not to bill for a chondroplasty. The other codes around a knee, there's a possibility you can get it, but again, you have to show medical necessity. So try not to unbundle codes, because that can definitely flag you for an audit, and that is a mistake. Now, one word that happens all the time, and I do a lot of medical testimony, medical expert work as well, is upcoding. That's something that you'll hear in a legal jargon quite a bit. So let's say if you're a physician in a certain specialty, let's say cardiology, oncology, hematology, you often see a lot of high complexity patients. And let's just say due to this, you always report the highest level E&M service, regardless of the actual condition that your patient presents with today. While this isn't always upcoding, you should accurately report the level of service based on the patient's condition today and not just based on your specialty. So there are also a lot of examples of outright fraud in terms of upcoding. We have to be very careful. So there was a psychiatrist recently that was fined $400,000 and permanently excluded from taking part in Medicare and Medicaid due to upcoding. So this provider billed for 30 to 60 minutes face-to-face sessions with patients, when in reality, he was only meeting with patients for about 15 minutes to just do a medicine check or a medication check. And so that is upcoding. That's a problem. So make sure that you are not making that mistake and you're coding what you're doing. And even if you've been trained on the 2021 rules, make sure that you have somebody that's either internally spot checking and auditing charts, or please give us a call, email us, request a chart review. We have a minimum of 30, but it may be just a due diligence and maybe give you some insight to make sure you're not upcoding. And who knows, you may be undercoding, so something to take a look at. Number 3 would be failing to check National Correct Coding Initiative edits when reporting multiple codes. Oh my gosh, that is such a big mistake. The Centers for Medicare and Medicaid, so CMS, they developed this Correct Coding Initiative to help ensure correct coding methods were followed and to avoid inappropriate payments for Medicare Part B claims, which is what we bill for. Those are professional claims. These are automated prepayment edits. They're reached by analyzing every pair of codes billed for the same patient on the same date by the same provider to see if an edit exists in the NCCI. If there is an edit, one of the codes is denied. And these edits will also typically provide a list of CPT modifiers available that you might be able to override the denial in certain circumstances, but they're saying that there is no modifier that can be used to override a denial routinely. And so you have to be very careful. Let's say that you were billing for a lesion excision and skin repair on a single service date, but CPT coding guidelines say that simple repairs are included in the excision codes. So separately coding the repair would be wrong and generate an NCCI edit or denial. But if the repair, let's say, was performed on a different site from where the lesion was removed, it may be appropriate to bill for both and append a modifier to let the payer know the procedure was indeed a separate from the excision. And that's another reason why the 59 has subset modifiers. So you could put an XS for separate service, and then that would be an appropriate use of overriding that potential edit. So really make sure that you're not falling into that mistake for not knowing your edits. Number 4 would be failing to append the modifiers, appropriate modifiers, or appending inappropriate modifiers. So let's say that related to the case we just talked about, it could involve reporting a 50 modifier bilateral procedure to a procedure code that already includes a bilateral service. Or let's say you put a modifier 59 on, or 50 on a add-on code. Remember in 2019, Medicare and AMA said that is no longer accurate. So you would not put a modifier on an add-on code, and you will get a denial if you even try. So, and it even says it in CPT book right now. So make sure that if you are appending modifiers, that you're appending the appropriate modifiers, and you're not appending an inappropriate modifier. I know I've talked about that dermatology nightmare that's going on right now with the 25 modifier on an E&M on the same date that you excise a lesion, or I should say that you treat a lesion, not necessarily an excision. But if it's all about the lesion, then it wouldn't be appropriate. Now the next one, and this is interesting. So what number are we at now? 1, 2, 3, 4, 5. So 5 is overusing modifier 22, which is an increased procedural service. So first of all, you must include proper documentation to explain why the procedure requires more than the usual work. And this is really important because I actually train offices when I do a modifier webinar to really add it on the back end. Once you get paid for your service, then go back in and appeal it. Sometimes it just makes it easier, especially with private payers. But let's say that you did it on the first time. So let's say you excise a lesion, let's say located in the crease of a neck from a very obese patient. The obesity makes the excision more difficult, and in such a case, appending the modifier 22 to remove the lesion may indicate that the increased complexity of the service was there. I had recently a general surgery situation where we had a patient that had an inguinal hernia, and it was slightly attached to the bowel, and we had to do a small incision to detach it and then sew up that area of the intestine. Well, there's no code for that, and unlisted code didn't seem appropriate, so we basically coded for the repair and then coded for with a 22 modifier, and we're able to get additional reimbursement. But you have to include proper documentation. Also in the Medicare manual, they say that if you don't include it the first time through on first pass, then you can't even appeal. You can't say, oh shoot, I forgot, and add it later. It has to be on the first time. So that is a pretty big mistake if you don't remember to do that, or if you overuse that 22 modifier. And remember, it's not just for extra time. It has to be extra work and all of that. Number 6 would be improper reporting of the infusion and hydration codes, which are time-based. Some people don't realize that. So good documentation of the start and stop times, those are essential for medical coders. You have to properly document that, or have your physicians document that, for you to be able to bill for those services. And then there are also some wrinkles involving services that are provided over a 2-day period of time. So there's a lot of kind of complexities that go into that. An example would be a continuous intravenous hydration for a patient. It's given from 11 p.m. to 2 a.m. while your date changed. So in that case, instead of a continuous infusion, you would code 2 administrations. They would be reported separately as initial 96374 on day 1, and then sequential 96376 on day 2. So not only do you have to watch the time, you have to watch the date. And that can cause a lot of improper reporting of those codes. So that's really important to be just be proactive, be mindful, and be alert when it comes to those potential mistakes. And then let's look at improper reporting, number 7, of injection codes. So only report 1 code for the entire session, which the injections take place, instead of multiple units of the code, if that's what the code says. And make sure you're always reading, which brings up another point, you're always reading those codes description. So whenever a code says injection or injections, where it gives you a plural in parentheses with an S, or biopsy or biopsies, then that would mean you cannot report that code twice. It means that that's all inclusive. I recently was talking to a provider, a derm doc, seems to be one of my new specialties, that was doing some skin tag removal, and the 17,000 code says up to 15. Well, he said, yeah, I can bill that 15 times up to 15. I'm like, no. You bill it up to 15 skin tags. And we went round and round until I went word for word for word of the language. And finally, the light bulb went off. And I said, no, it's once up to 15. And then you can add on after that with an add-on code. So really taking the time to understand not just injection codes, but procedural codes and their limitations and their plurality is a really big deal. What about reporting unlisted codes? Well, that's another thing that you have a one shot to get it right. If you try to report it without documentation, that's our mistake number 8. If you must use an unlisted code, that means you just can't find a code that properly identifies what you're billing for. And to bill for a service, then you must properly document it and hopefully relate it to, some other code that you can price it out as. But this is a really big deal, and we want to make sure that we're not falling into that trap of everything should be unlisted, and then you try to submit it without documentation. Also make sure if you're using unlisted codes that you're in the right specialty. Somebody asked me the other day about they were in a cardiovascular procedure and they wanted to use a medicine unlisted code instead of cardiovascular surgical unlisted code. And I was like, okay, you're mixing apples and oranges here. So you have to be very careful with knowing also what is your specialty and where is the area there. Okay, so here is number 9, and this one it's just kind of interesting to me because one of my specialties is orthopedic, as you know. And yes, everybody always asks me what your specialty is. Number 1 is cardiology and peripheral cardiology. I love it. And EP, anything cardiology, that's me. And then gastroenterology, orthopedic, apparently dermatology. I'm also the external consultant for the American Academy of Family Physicians. So a lot of family practice, a lot of internal medicine. And then I dabble in other things. So obviously now telehealth is a delivery of medicine. Remember, it's not a specialty. So I'm big on that. And then general surgery, and just keep going on that. But I try to really give my expertise and say I'm an expert in about 7 specialties. Nobody can be an expert in every specialty. And if anybody tells you they are, be skeptical, because you just can't. You can't keep up. And so you can probably handle anywhere from maybe a half dozen to maybe one more, but just know that it's tough sometimes. But here's one that comes up with orthopedic quite a bit. So a patient comes in, and they're coming in for a possible fracture. And so let's say a new patient reports to the orthopedic surgeon and complaining of left wrist pain. The physician does an evaluation management service. I'm tongue-tied today. So an E&M code. They determine that there is a fractured wrist. They also did an X-ray to confirm that. And then they performed closed treatment of a single, let's say, carpal bone without mention of manipulation. So they basically will just cast it, if you will, or just make sure that it's stable. So on this claim, what do you do with that? Well, it says closed treatment, and that's very vague, but closed treatment of carpal bone fracture, including carpal scaphoid navicular, without manipulation. So they're not doing anything to set it back in place. They're just making sure it's stable. And it says each bone. So for the fracture care, you would have the 25630. You would indicate laterality. Let's just say this was the left side, so you'd put an LT on it. And most payers do require that. You may also get an office visit because it's not considered a minor procedure. So you would get a 99203, new patient to you. And this is either timed at 30 to 40 minutes, or typically fractures right now on the risk of a presenting problem are considered low level. I know I have some doctors that are not happy about that. And they're also considered low level on the risk as well. So not just on the presenting problem, but the overall risk, and you would only have a minimal data point with ordering an X-ray. And then you'd modify the 57 modifier to the 99203, and then you would have a global period on the 25630. Okay, so that works. That's fine. But here's where some of the mistakes happen. What happens if the patient was established and reports to the orthopedic physician for a scheduled repair of their left wrist coming from a primary care office? They took the X-ray and they said, we know they have a fracture. They're holding their wrist. We just put a little ace bandage on it and they're coming over. And the notes indicated, even if it was a new patient, that the orthopedist discussed the treatment for the patient, the course of recovery. I'm saying the surgery, but basically to put them in a cast, and patients don't think it's a surgery because they're not a splicing there. And then they performed a closed treatment without manipulation. Well, on this claim, the E&M is part of the work units for the wrist repair and to basically put it in a cast. And so you'd only report 25630 LT for this patient. And I know that that's hard to grasp because everybody wants an office visit every single time there is a face-to-face encounter, and it's not always accurate to get one. So that is a big mistake that we have happen a lot of times, and we don't want to fall into that. And then my last one for the top 10, this is number 10 today, and you knew I was going to talk about telehealth. I don't seem to be able to get out of that. But here's a question that came in. It says, Terry, our provider performed an office E&M service over the phone that lasted 55 minutes. Can we bill a prolonged service code 99354 in addition to the telephone code 99443? Well, one thing that's good about this is that they went right to the telephone code because it was an audio only. They said over the phone. Now, it could depend on payer. Commercial plans may let you do it, but let's just talk about Medicare. Medicare has a new prolonged service code, the G2212, and I also know that there's one for the level 5 99417 for commercial plans. And I didn't say this was a level 5. All this is a phone call. But they will not allow the other prolonged service codes for anything that's not an out or inpatient visit, again, not the new office visits. And so this would be incorrect to try to put a prolonged service code on a long phone call. Also, during the pandemic, which was just renewed, by the way, glad I just remembered that, we got a renewal just Monday. I can't believe they waited so long, until October 20th now. But if you're still providing telehealth services, again, to slow the new variant, to slow the stop of COVID, not for convenience only, and you exceed that time limit, they said there is nothing extra. We gave you a code up to 30 minutes. After that, you're on your own. And so, no, there is nothing extra. And please don't make that mistake. Telehealth audits are on the rampage. So that is a really big mistake, especially during the pandemic. That is what is on the OIG work plan as of January, and they are finding so much abuse that they're probably going to be able to lower our deficit with what they find. It's just crazy. So we want to make sure that we're clear there. So hopefully some of those potential mistakes, I gave you some insights so that you don't make them, and you just really be mindful and do due diligence before you get into the potential of having some errors there. You just don't want to deal with that. So our Top 10 Tuesday is also brought to you today by Do, the nation's #1 retirement app, Forbes' top-rated finance blog, do.com. That is DUE.com. And I appreciate the shout out I got. A couple of my friends, I know Denise, who's a longtime friend of mine, longtime fellow coder in orthopedic in California, for when I put out something that was about the Keepsake app and how you can frame. I had several people ask me for that, and they said, "Oh my gosh, this is so easy." Yes, watch your checkbook, because boy, that is so easy to do. And we just want to make sure that you're not getting crazy with it, because I know I can. So my personal tidbit today actually isn't probably so personal. It's a little bit business, I guess. I know I've put on here my top 10 pet peeves before, but I saw something really funny. And if you follow me on LinkedIn, please find me, because I posted something today around, this morning, and it just was about HIPAA versus HIPAA. So remember your acronyms: Health Insurance Portability and Accountability Act from 1996 is HIPAA. It's not HIPPA. Okay, that somebody made that up. And so make sure that you are accurate when you report acronyms, when you email somebody, get their name, spelled right. But it is really important to just watch certain things that can be maybe a trigger for somebody. I just like a professionalism, and I posted something just kind of funny about it, just so if you happen to take a look. Also, a shout out to my friend Sunil Patel. She interviewed me today for an upcoming Paint the Medical Picture podcast interview that she did with me, and it was great fun. So thank you, Sunil, for that, and hopefully you're following her and picking up her podcast as well. She does a great job, great interviews, and I like how she themes things and just really talks to people in healthcare about their background, but she's all about compliance. So if you get a chance to pick up her podcast, you won't be sorry. And finally, I'm going to just say shout out to my husband, Tom. We are celebrating our 22nd anniversary this weekend. So, and we have this certain place we like to go to, just a sandwich shop. We go down the beach for a while. So I'm excited just to have a really relaxing weekend. I record prior to my Tuesday drop. And so anyway, we're excited about that. So thanks for listening today, and I will talk to you next week. Everybody make it a great day and a great week. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.